are you doing today, Dr. Cockerell?
Good. It's finally cooler weather. It makes it feel a lot better. All right, who wants to give this one a go?
I'll give it a shot. My name's Danny. Good to meet you.
Oh, nice to meet you.
Wonderful. So I'll start by saying here we have a deeper punch biopsy.
Yes.
When I was reviewing, I noticed the presence of sebaceous glands, kind of these foamy circular structures, follicles as well, hair follicles. And when I took a deeper dive underneath, I noticed some cartilage.
Okay, good. So what part of the body do you think you might be on
I
here?
was between two sites, either an ear or a nose.
Good. Occasionally we'll get cartilage in other situations, like if we biopsy, say, a mixed tumor of the skin that's undergone cartilaginous metaplasia, or sometimes if you biopsy, say, like a lesion over the digit, might be some cartilage from the underlying joint space. But yeah, for the most part, if you take something this deep as a punch, it's going to be one of those two locations. Of those two, which do you like better?
I, perhaps the ear. I don't have any particular.
Yeah, it's probably the ear. Usually the nose is going to have a lot more sebaceous glands than here.
Okay.
Our nose has lots of follicles and sebaceous glands. So this would be more likely the ear, but yeah, it's not absolutely critical. But I think you're right. So where do you think the pathology is located here primarily?
I think in the epidermis and the upper dermis, perhaps.
Do you think we're looking at abnormality up here?
Yes, that's what I favored.
Okay. Did you think that cartilage was normal?
I did, but now I'm second guessing myself.
Always nice. Yeah. Professor sort of starts querying your answer there, but
Exactly.
walk me through what you thought was going on up here, because
Okay.
pathology up here, and then we'll talk.
Maybe okay, maybe these were all just incidental findings up in the epidermis, but I noticed most at starting from the top, there was ortho keratosis pretty normally, and then at some follicles, I believed I saw some like follicular plugging and parakeratosis, especially on the slice and the other slice, as well as some. There we go. And then what I thought was spongiosis and then some perivascular infiltrates. So this person probably has seborrheic dermatitis in addition to whatever's going on with their cartilage. It was my best guess.
Yeah, no, that's not a guess at all. That's exactly, I agree with you completely. It's got a little bit of parakeratosis, kind of shoulder parakeratosis around that follicle. You do get spongiosis to some degree and seborrheic dermatitis. It's also possible this could be a little folliculitis that we're kind of off to the side of. So yeah, this isn't totally normal. I agree with you. However, let's take a look at this cartilage. So if you biopsy, say, just somebody's ear normally, or you maybe say you went to an autopsy and they took off the person's ear just to look, produce an example of normal cartilage. What does that generally look like?
Hmm. Think you caught me in a pickle. Is it more chondrocytes like the ones? Is it pinker?
Generally tends to be a little bit more basophilic. It's got a lot of hyaluronic acid in there. You see the nice chondrocytes and everything. And then you don't usually see these kind of degenerated chondrocytes here with this more eosinophilic cytoplasm. And then if you notice this kind of change, you can see these cells are dying here.
Okay.
They're rupturing, and then now you've got some fibroplasia and some fibrin and some inflammation in this little focus right here, almost like scar tissue is forming in a way.
Understood. Could this be an early chondrodermatitis nodularis chronica?
Well, chondrodermatitis nodularis helosis.
Helis.
What's
Excuse
the
me.
pathophysiology of that entity? What happens in chondrodermatitis? What's going on there?
So that is, for some reason, patients who are believed to be sleeping on one ear, not perfusing as well as my understanding, cause more of a neoplastic pathology leading to, then there's fibrosis of the cartilage, and it's kind of like coming up through the epidermis, causing ulceration, which I didn't really see here.
It's basically like lichen simplex chronicus overlying an area where the cartilage is really close to the skin. Here, I'm trying to figure out where this would have been. It's probably, I don't know, maybe they biopsied some of maybe the ear lobe and kind of were going north, because there's a lot of skin between the epidermis and the dermis and the cartilage. Normally, if you biopsy somebody's ear, there's really not a lot of skin between that. So I'm not sure how they did this, because it's got a lot of relatively normal appearing skin above this cartilage. If you biopsy somebody with chondrodermatitis, usually it's a shave biopsy, and you'll see a little bit of cartilage down here, a little bit of fibrosis and inflammation, because it's really, and then overlying epidermal hyperplasia. It's basically trauma, lichen simplex chronicus, superimposed on an area where there's really not much skin between the cartilage and the outside trauma, and some call it an ear corn, quote unquote. So this would be a little bit funny to be chondro, because the cartilage changes are so deep here.
Understood. Okay.
Usually also the damaged cartilage there is just kind of the surface, because you've got epidermis, fibroplasia, and then the altered collagen of the cartilage, just of the cartilage rather, just right beneath there. Sometimes you don't even see cartilage, you just see fibroplasia and some inflammation with the epidermal changes. So here we've got cartilage, looks like here, that's got some abnormality in the center of the cartilage. So it's almost like it's degenerating from within. It's sort of centrally dying, if you will.
Gotcha. We need to phone a friend for pathologies of the cartilage.
Yeah, so what are some diseases that can give you degenerated cartilage like this? Or just diseases that cause cartilage damage that we know about in dermatology? There really aren't too terribly many, really only probably about 2 or 3.
Okay.
What about relapsing polychondritis?
Yeah, that's one that you think about for sure. And does this look good for that?
I'm not quite sure,
Okay.
but inflammation of the cartilage.
Yeah, do you see much inflammation of the cartilage here, actually? You really don't. You've really got more kind of cartilaginous degeneration here with this granulation tissue and scar-like reaction that's occurring kind of in the center of this little cartilaginous plate here. With relapsing polychondritis, you get a lymphocytic infiltrate that comes in from outside, and you see lymphocytes that are percolating into the cartilage, gradually destroying it. This looks like it's got some kind of ischemic change that's going on from almost in the center of the cartilage. Does that give you any potential clues to what's going on? And this, you may not have reached this chapter in the book yet, but this is what happens when you get not just superficial trauma like sleeping on it. This is what happens if somebody hits you in the ear with a baseball bat, or this is what happens when wrestlers get into wrestling and they, grabbing each other in these headlocks, and they keep constantly traumatizing their ears. It's usually kind of blunt trauma over and over again. And the cartilage generates from inside and gets replaced by scar tissue, and they lose the actual substance of the cartilage. And then their ears, after a while, start getting smaller, and they start looking like cauliflowers. Cauliflower ear, well, that's basically how it happens. That's the pathophysiology of that. And what does the ear look like in someone that's got relapsing polychondritis? What's the term that we use for those kind of ears? Nobody knows? They get floppy. It's like, it's like dog ears, like bloodhound ears. The ears, they lose the structure of their cartilage because you just gradually sort of goes away. It doesn't get replaced by scar tissue. It just gets gradually eaten up. And then the ears just become floppy. So, and then it's usually at the top of the ear. These things can involve the entire pinna, the whole thing. You know, they just destroy all the cartilage because they basically put them in, they get in these headlocks and they put their entire ear in those headlocks. And so this is what's known as pseudocyst of the auricle. Not really and truly a cyst, because it's cystic, if you will. But basically what happens here is just ischemic destruction, damage of the cartilage gets replaced by this, you know, fibroplasia, granulation tissue. This material here is probably degenerated hyaluronic acid. So if you get one of these things early and you try to I&D it, this oily material comes out of it. Basically, that's where the cartilage is just destroyed. It turns into oil, basically. It's not really oil, but it's basically kind of like hyaluronic acid that just it's degenerated, and you can actually express that out if you actually I&D these. Generally, we don't do surgery on these. They just kind of gradually turn into this scar tissue, and there's really not any good way to treat it once it turns to this. So this is pseudocyst of the auricle. So notice where the damage is. Now, if they were to show you something like this on the board examination, they would probably be wanting you to distinguish this from relapsing polychondritis, because that is it's autoimmune disease there. It's an inflammatory condition where you get lymphocytes that are attacking the cartilage, and then it doesn't only attack the cartilage of the ear and nose and places like that. They get, you know, saddle nose deformities. They can get involved in their larynx and tracheobronchial tree. So and they get arthritis. So it attacks basically all of the cartilage of the body, and they get a lymphocytic infiltrate in here. Notice here, there's virtually no inflammation. It's basically just degenerated cartilage from trauma.
Very cool.
All right. If you see that movie, I don't remember that's about wrestling a few years ago that Steve Carell was in, and every one of those kids they had the cauliflower ears basically in the movie. That kind of goes along with it. Okay, who wants to give this one a go?
I can give this one a go. It looks like a kind of like an endophytic, almost nodule. It looks like maybe a punch.
Yes.
And you in the middle of the lesion, it kind of looks like it's like almost connecting to the surface. There's maybe some like acantholytic areas and some villi appearing structures. And whenever you look at higher part, it looks like there's some corons and grain appearance. So I initially thought this was like a warty dyskeratoma.
Okay, good. So tell us what a warty dyskeratoma basically is. You said you thought it was a tumor. Do you think it really is a tumor, or what do you think?
It's probably not a tumor. It's probably just like a benign like endophytic growth.
Yeah, it's actually kind of like a cyst. You see, it's kind of looks like a little sort of endophytic cyst. There's the follicle. So one way to think about this is it's basically just like a cyst that's lined with the exact changes that you described, which is acantholytic dyskeratosis. Beautiful, as you pointed out here. These are the corons and grains, which is just the French words for coron, just means round body. They're acantholytic dyskeratotic granular cells and spinous cells, and grains are acantholytic dyskeratotic parakeratotic cells. There's nothing special about this. It's seen in any of the acantholytic dyskeratotic conditions. And the good news is you were able to figure out the diagnosis pretty quickly. The bad news is that there's about 5 or 6 other diseases that give you this histologic reaction pattern. So what are some of the other diseases that give you this pattern? Because the board definitely is going to ask you about this. So you may as well just go ahead and surrender to the fact that you're going to be quizzed about all the different diseases that can give you acantholytic dyskeratosis.
Yeah, other things you can think of as well include like Terrier's disease.
Aries is one. Okay.
Hailey, Grover's.
Grover's is. Does Hailey-Hailey look like this? We sometimes get sort of lumped in there, but
No, you get more like confluent kind of like a dilapidated brick wall appearance, not as much focal.
doesn't give you this nice cleft here like this. It's usually kind of just the entire epidermis is still contiguous with the underlying dermis. The whole thing just kind of just, like you say, just sort of degenerates, if you will. You get acantholysis sort of diffusely through the epidermis, and usually don't get quite as much dyskeratosis in that. So I don't like to lump Hailey-Hailey into this because it really looks pretty different.
Mm-hmm.
There's a couple others though that can do it. They said Derriér's disease. What if it was just a linear lesion and you biopsied it and it looked like this? Or it had this kind of reaction pattern. It didn't have the cystic morphology to it.
Could it be like a let's see, like pemphigus?
Well, we're talking about, let's say, just an isolated linear lesion that maybe followed Blaschko's line, say on someone's arm, and you saw the patient, that looks interesting. Maybe they've got poison ivy, maybe they've got, some bizarre Lichen Sclerosus or something. You biopsy it, and then it shows this. It shows acantholytic dyskeratosis. Are you going to go back to the patient and say, you've got Grover's, or what are you going to tell them they have? And it's a linear plaque following Blaschko's lines. Are you going to tell them they have Derriér's?
You tell them it might be like an acantholytic dyskeratotic nevus.
Yes, good, excellent, perfect. Exactly. So you can get focal acantholytic dyskeratotic morphology like this in a linear pattern, and that's an epidermal nevus. So you can see a lot of things. Epidermal nevi are sort of like Forrest Gump, you don't really know what you're going to get until you open up the chocolate bar a little bit there. So, sometimes you biopsy an epidermal nevus, you see this change, you see epidermal hyperplasia with papillomatosis. Sometimes you can see features of the nevus sebaceous. Sometimes you see epidermolytic hyperkeratosis. So yeah, you can get, and some people call that linear Derriér's disease. And what's thought to happen is basically that's a somatic mutation that gives you the same mutation that they get in Derriér's, the generalized form, and it's just in a localized area as an epidermal nevus. So yeah, you just have to realize that you can see the same kind of reaction pattern in that. You mentioned several other conditions. There's maybe one or two others where you can see this. So the concept of epidermal reaction pattern showing up as different clinical, features, just like, for example, spongiosis is an epidermal reaction pattern. You see contact dermatitis, nummular dermatitis, id reactions, and things like that. Well, here we got focal acantholytic dyskeratosis. You can see Derriér's, epidermal nevus, Grover's, you mentioned. There's about a couple of others. You're running out of your list, may be exhausted. Anybody else know of a couple other things where you can see focal acantholytic dyskeratosis? And it isn't Derriér's, it isn't an epidermal nevus, it isn't Grover's. Nobody knows. The whole collective wisdom of the group, no one remembers.
Is there an acantholytic acanthoma?
Yes, good. Sometimes somebody comes in with a solitary lesion, rule out basal cell, do a shave biopsy, and boom, it shows focal acantholytic dyskeratosis. A solitary acantholytic keratosis, good, exactly. And sometimes you can get disseminated keratoses like that too, that's not Grover's disease. So yeah, that's a good point. And those clinicians never, ever diagnose that. They think it's a basal cell or like actinic keratosis or something like that. And there's one final one that's rare. It's kind of a zebra. It's called familial dyskeratotic comedones. They have the multiple little lesions that look kind of like comedones or keratosis pilaris, and you biopsy one and boom, it shows focal acantholytic dyskeratosis like this. So good, that's good. And so what's the mutation in Derriér's? You guys have to know all these genes.
ATP2A2.
Good, and it's like a calcium channel business, I think, here. Some people even tried using calcium channel blockers and things like that to treat that. Okay, good. So that's a classic sort of board exam kind of question. They're definitely going to ask you stuff like that. So just be prepared for that. All right, this one's a little bit of a Ignore all this stuff that looks like a four-leaf clover. This isn't the world's best example of this, but it's sometimes we get shaved biopsies of things like this. So I'm going to give this one a try.
I can go.
Okay.
So it looks like we have like a shave. I think we're acral skin.
Good. Excellent. Why do you think acral?
So I see it like a stratum lucidum, and then it's also the stratum corneum is like quite thick.
Good. And there's really no follicles. Maybe I think that might even be a sweat duct here. So we don't see any follicles. So we're either near palmar sole or we might actually be on palmar sole. It could be like around the palmar sole. I agree completely. Good.
Yeah. And so it's probably not like an en face or like the normal cut of it. So the really just a little strange. But if we look, I think it's neoplasm. When we look deeper, there's a decent amount of vessels, and then maybe a little bit of fibrosis.
Benign or malignant?
I think benign.
Totally benign, right? Very symmetrical, very well circumscribed. Epithelial or non-epithelial, or maybe both?
Yeah, probably a little bit of both.
Okay. Yeah, so this is not normal up here, right? I mean, what's wrong with that part?
Sorry, I didn't catch that part.
This is obviously not normal here. What's the pathologic abnormality we're looking at right here in this area?
Yeah, it's like acanthotic.
Good, markedly acanthotic, hyperkeratosis, hypergranulosis. So you can imagine, what do you think this thing would have looked like clinically? Patient walks into the clinic. What do you think this thing's going to look like?
Sort of warty.
Yeah, good. It's going to be like a small dome-shaped papule. It's going to possibly look like a wart. It's going to be verrucous, probably pretty firm palpation. And then we go to higher magnification, and yeah, there's some dilated blood vessels, like you said here. What about these collagen bundles?
Yeah, it looks like there's more of them. Or it's kind of like.
Yeah, I would agree with that. Okay, so they're a little bit thickened like that. So what's the differential diagnosis here on this?
Given the location, you can think of like acquired digital fibrokeratoma, or like angiofibroma, kind of like a Conan's tumor.
Okay, that's something you would think of. And what's the last thing you'd probably throw in there?
Sorry?
What's the last thing that you would probably toss in the differential?
I mean, I don't see like, it's not really deep enough to see these, but like you can get extramemory digit or.
Okay, that's good. Yeah, but that's not a bad idea. I was thinking you might throw in an acral verruca also.
Yeah, verruca, yeah.
Okay, good. So yeah, all those things are what you're going to put in the differential diagnosis. Well, this actually is, I'm not going to spend a lot of time on this one, but basically this is an example of an acquired digital fibrokeratoma. It's just a little funny. Usually these are more fibrotic than this. So this one's got some blood vessels. So I don't think the board would show you this and throw in the differential of an angiofibroma. It does have some angiomatous components to it. Usually when you look at those lesions associated with tuberous sclerosis, Keenan tumors, or however you pronounce that, they have a little bit more, they don't have quite this much verrucous hyperplasia like that. They sort of look that clinically like cloves of garlic. But this was an example of an acquired digital fibrokeratoma, so it just shows exactly what you're supposed to see. Now, what's the thing that sort of militates against an acral verruca here? The one thing that, last point in this case, that sort of says it's probably not that. Doesn't mean it isn't that, but it's probably not that.
I mean, there's like a granular, but it's not all that thickened.
And you don't really see any coilocytic change. So you just have sort of hypergranulosis, hyperkeratosis. Some of that may be related to trauma. So it's if it's going to be an acral verruca, you're almost always going to see some coilocytes, which we really don't see here. So that's just an example of a variant of acquired digital fibrokeratomas. It's not the world's best one, but it shows how they can simulate warts and other things like that. All right, good. Move on to this one. All right.
Next one.
Okay, good.
So this looks like a shave of a neoplasm, likely. We appear to be on acral skin. It looks like there's this large cystic space as well as this kind of tumor of like basaloid appearing cells.
Plastic process.
Mm-hmm.
Okay. And do you
And
think
then
it's
mhm.
more what do you think is benign or malignant, just based on what we have here?
Yeah, I mean, it's pretty symmetrical and well circumscribed. I think it's possibly benign.
Yeah, I agree with you. I agree. We unfortunately don't have the whole thing. I mean, I guess if you look at this piece, you can kind of draw a little line around that. So, well, maybe this was kind of the whole thing. It's got this sort of fibrotic area on the periphery that some people refer to as a capsule. You know, they're not really capsules, but they're just kind of compressed collagen at the periphery. Okay, good. And so epithelial or non-epithelial? You said basaloid kind of cells?
Yeah, I think I was thinking it was more kind of like ecrine differentiation.
Okay, so that's basaloid then, right? Or it's epithelial. Good, epithelial differentiation. Of course, we have several different types of epithelium, and ecrine is one of those. Now, how do you tell ecrine when you're deciding it's an ecrine type of differentiation? What criteria do you use to make that determination?
I kind of felt like some of them are kind of making like sweat ducts or
Look for ductal differentiation, like here and here. What about the cells themselves?
they're pretty kind of I guess the shape of them, some of them look kind of like polygonal or they're pretty dark blue.
They're basophilic, they're small, they're round, and they're admixed with some cells that are a little clear staining. That's fairly characteristic of cells that are thought to be ecrine differentiation. So those are some things that you can kind of look for to help you. Another thing sometimes that we see is this kind of morphology. You get this kind of pink hyaline fibrin-like change within these lesions. Sometimes in lesions such as like spiranomas, you'll see those little tiny pink globules in there. The stromal changes in some of these neoplasms does kind of look like this sometimes. It's kind of an interesting morphology. Okay, so you think it's ecrine, benign. So what's the name of this thing?
So I was thinking this was a hydradenoма.
Good. Hydradenoma, H-I-D-R is I think the Greek word for sweat, if you will, and so basically that's HID means it's not HYD, which is water, so it's hydradenoma. And you can see it does have these little clear staining cells, the cuboidal basal cells here as well. Now, it is nodular over here, but this other area, what do we refer to this morphology as here? Where we've got this markedly large, clear area with these red cells in it. What do we call this?
Cystic.
Yeah. So what's the real final diagnosis of this lesion?
A nodular hydradenoma?
Well, it's nodular over here, but we often refer to these as solid cystic hydradenomas when they've got a cystic component like this. That's more of just kind of a little icing on the cake. You know, the fact that you got it as a hydranoma is by far the most important thing here. So they're not going to quibble about that. But the main things you described are exactly what you want to be able to see. Look for ductal differentiation, look for these individual sort of clear admixed with these cuboidal basaloid basophilic cells. That's good evidence of ecrine differentiation. What would sort of, if this were maybe an apricot lesion, what would you be looking for that we really don't see very well here?
You like apricot secretion?
Yeah, good. You look for decapitation apricot secretion, which we do not see here. And a lot of people, You know, my former mentor, Dr. Ackerman, used to quibble about whether these things were eccrine versus apocrine. He'd look at these things for 5 minutes and he'd find one apocrine cell and he'd say, these are not eccrine after all. I don't think anybody cares. But the most important thing is that you were able to make the diagnosis. Now, there's one other teaching point about this case to bring it full circle. We're on acral skin. What is the differential diagnosis of this lesion on acral skin that we have to be concerned about when we've got an eccrine or an adnexal neoplasm on acral skin that we must keep in the back of our mind and make sure we're not missing?
Yeah, I also thought of a digital papillary adenocarcinoma.
Excellent. That's the one thing you need to always keep in mind. Now, not everything that's eccrine or apocrine that occurs in acral sites is aggressive and is going to kill the patient or anything like that. This one has really no cytologic atypia, no mitoses, nothing to that degree. So this was a benign lesion, but that is something that you do need to keep in mind. And sometimes they can be fairly bland histologically. And so we often recommend removal of these lesions. The one thing about these adnexal neoplasms, if you leave them alone for a long period of time, they can sometimes become malignant. They can degenerate into malignancy. It's relatively rare, but that actually happens also in other neoplasms in the body. For example, the salivary gland is pleomorphic adenomas that can degenerate into pleomorphic adenocarcinomas. So the same thing sometimes happens in these adnexal tumors. And so for that reason, they often, we recommend sometimes that they get removed. You just don't want to leave one of these large lesions in there for 25, 30 years and it becomes cancer when you could have prevented it by removing it earlier. But no, that's good. That's exactly what this was a solid-cystic hidradenoma. Okay. Next one.
I could do this one.
Okay.
So this looks like a shave biopsy, and it looks like a neoplastic process.
Okay, good.
And then I was leaning towards malignant because from this tower we can see that ulcerated.
Yeah, it is ulcerated. This unfortunately is not very well processed. Now that's probably, it might be a consequence of the lesion itself. But yeah, I think you're right. It is kind of ulcerated, which can be a sign of malignancy. What about symmetry?
I think it's not very symmetrical.
Yeah, I agree. It looks a little thicker over here. You've got a component over here that might even be kind of intraepidermal to the side. It's not super well circumscribed. You've got some cells out here that seem to be kind of getting into the collagen at the periphery of the lesion. So yeah, I agree. It looks suspicious at low magnification. So what kind of differentiation do you think we're exhibiting here? Epithelial or non-epithelial?
Non-epithelial.
Okay, non-epithelial. Now, why non-epithelial? I'm going to go higher magnification here.
I was thinking because it's in the dermis and we see a bunch of sebaceous glands or sebacites.
Okay. Sebaceous glands, is that epithelial or non-epithelial?
Oh, it is epithelial.
Yeah, it's a type of epithelium. We tend to forget that. So we say, well, epithelium means squamous epithelium. Well, no, there's a lot of other types of epithelium in the body, and certainly in the skin, we've got about, 5 or 6. So yeah, so you think this is sebaceous differentiation, which is a type of epithelial. So malignant, you've decided, sebaceous differentiation. What's the diagnosis?
I was thinking it's sebaceous carcinoma.
Yeah, has to be if it's malignant. Okay, so let's look at a higher magnification. So we think at low magnification it looked malignant because of the various things we just said. We've got a higher magnification. What are some things about sebaceous carcinoma that favor malignancy versus benign?
This one looks poorly differentiated.
Is this poorly differentiated really though?
I thought there was like a lot of basaloid cells.
Yeah, and okay, so the sebaceous gland, when you think of it, What are the three components of the sebaceous gland? Kind of looking at it a little bit right here. So what's the one that we always think about when we think about sebaceous gland?
We think of multivacuolated structure.
Yeah, you think about the well-differentiated cells that are basically filled with the lipid that then they undergo this exocrine secretion, holocrine secretion, where everything inside the cytoplasm gets dumped into the follicular lumen, and that's the stuff that gives you the oily skin that the Corynebacterium love to munch on. So that's basically the well-differentiated sebaceous cells. That's one component of the sebaceous gland, sebaceous lobules with the well-differentiated sebaceous cells. What about these cells? What are these?
I thought those were just basaloid cells.
They're the germinative cells of the sebaceous gland. So these are like the stem cells that then differentiate into these cells and ultimately to these. So these are the small round cells that you don't really see on a regular normal biopsy of a sebaceous gland. I don't know if there's another sebaceous gland in this specimen. There's not. But if you look at a regular normal sebaceous gland, you don't really appreciate those cells because there's like one little tiny thin layer of them. But if they become neoplastic, those cells can predominate here. So these are the basaloid cells of the sebaceous gland that have resulted in this cancer, this neoplasm. Now you said, you said it was poorly differentiated, but it's not really poorly differentiated, right? If something is poorly differentiated, it means you can't really tell what it is. You know, like a poorly differentiated squamous cell carcinoma is basically like a spindle cell cancer that you don't really know what it is. And therefore you have to do immunoperoxidase stains and whatnot to really then figure out what it is. This one we say, well, you know, we can tell it's sebaceous here. It's got both the basaloid component and the more well-differentiated component. Okay. But what other criteria other than the architectural criteria do we use to make the diagnosis of sebaceous carcinoma?
You see cytologic atypia.
Yeah, you see cytologic atypia, good. You see mitotic figures?
Yes.
Yeah, and you see atypical mitoses. Now, it's normal in any germinative epithelium of the body, the matrical cells of the hair follicle, the matrical cells that end up making pilomatricoma, for example. These cells, if you get a benign sebaceous neoplasm of these stem cells here, these germinative cells, you're going to see mitoses in that. Okay, so you're going to see mitotic figures anytime you get a primitive epithelium. So you can't use that as definitive criteria for diagnosis of malignancy. You have to look at other things. Like you mentioned the asymmetry, you mentioned the ulceration, and this is a crummily prepared slide, but that may be because it's necrotic and ulcerated. So when you see necrosis on moss in a cancer, in a tumor, that really favors malignant. So anytime tumors start outgrowing their blood supply, you know, that's the sign of malignancy, like any kind of melanocytic lesion, for example, that's ulcerated, really and truly ulcerated, not traumatized. That's almost always melanoma when we see that. So here, all this stuff that's not staining well and poorly processed, some of that's artifact, but a lot of it's because all these things are dead here. This thing is just massively necrotic. Okay, so that favors malignancy also. And then what's going on over here? Let's talk about this for a second.
It looks like it's like that lobule's invading to that area.
It's in the epidermis. And sebaceous carcinoma is one of the neoplasms, here's maybe a follicle that's involved, that can give you intraepidermal involvement, even pagetoid intraepidermal involvement, like Patch's disease, like melanoma, like extramammary Patch's disease, like mycosis fungoides, like Langerhans histiocytosis. It's one of the conditions that can give you intraepidermal involvement, and sometimes you just see these sebaceous cells individually percolating in the epidermis, almost like melanoma in situ. So just realize that sebaceous carcinoma is one of the neoplasms that can give you an intraepidermal pagetoid pattern, interestingly enough. So this is sebaceous carcinoma. Now, a couple other things. What's the number one item in the differential diagnosis of this that often gets overdiagnosed as sebaceous carcinoma? Because people start looking at the mitoses and they say, oh my goodness, it's got to be cancer because it's got mitotic figures in it. What's the one item that simulates sebaceous carcinoma but really is not sebaceous carcinoma?
Is it sebaceoma?
Excellent, very good. And those are small lesions. They're often present in multiplicity. They can be solitary though. And what syndrome is associated with that?
Muratori?
Excellent. And then what stains do we look at to see if it might have Muratori syndrome?
Would it be EMA?
Well, actually, we look for microsatellite instability. You know, we look for MSH2, MSH6, MLH1, PMS2. We stain for those, and we're looking for loss of those markers. If they're lost, that's a sign that the patient may have Muratori. Now, sometimes you'll have patients that don't have much change in that, and they still can theoretically have Muratori. Sometimes patients have these loss of these markers, and they don't have Muratori. So it's not the world's best screening technique, but we do it in our laboratory, and at least the clinician knows that they've got that and they might possibly have it. So good, it's a good example. This is an example of sebaceous carcinoma here. Very good. Okay.
Okay, I can do this one.
Great.
So we have a shave biopsy, and then what really stands out is all the kind of extensive acantholysis that we see mainly throughout the epidermis.
Okay, good. We just talked about this a minute ago, didn't we?
Yes, we did, and yeah, on I think case 2. However, in this case, I don't really see a lot of dyskeratosis.
Yeah, there's a little bit up here.
Okay.
On a scale of 1 to 10, it's more kind of closer to the 1 range than before, where it was like 9. So occasionally a little bit of it up here, but it's certainly not to the same degree. And yeah, you're right. This is giving complete acantholysis throughout the entire epidermis here in some of these foci. So what's the most likely diagnosis?
So I was thinking most likely would be Hailey-Hailey's disease. Maybe you could also possibly think about pemphigus as well.
Okay, which kind of pemphigus? Is Hailey-Hailey disease a form of pemphigus?
I don't believe it is.
What's the other name for it?
For Hailey-Hailey's?
Yeah, it's Hailey-Hailey.
Oh,
rather.
I guess, yes. I guess it is. Benign familial pemphigus. So yes.
Yeah. But you're right. Is it have the same pathophysiologic mechanism as the other forms of pemphigus?
No, it's more genetic instead of like autoimmune.
Exactly. It's not autoimmune. So if you do immunofluorescence on this, it's negative, right? It doesn't show positive intercellular binding of IgG. It's not an anti-desmoglein antibodies that we see with the other forms of pemphigus. Okay, so you're on a board examination and they plop this down slide in front of you and they throw in, you know, these other forms of pemphigus. Are you going to be concerned about the possibility of pemphigus vulgaris if you kind of start focusing on an area like this?
I would be. I think especially where my kind of the pointer was. I guess not up top, but I could kind of maybe make out like possibly like tombstoning in the
you see a little bit of that. And the lesson there is don't use one criterion to make the diagnosis. So these guys, when they write these exam questions, they tend to be pretty tricky. You know, they say, what's the best answer? Okay. So there may be signs that would fit with pemphigus vulgaris. There is so-called tombstoning here. Okay. They may say Puderi's disease in here. They might throw that in and say, well, gosh, there's a little bit of acantholytic dyskeratosis up here. You know, they might say Grover's disease. You know, or you can get a Hailey-Hailey form of Grover's disease, but it's never this extensive. And, you don't see the full thickness acantholysis, that so-called dilapidated brick wall appearance we're talking about in pemphigus virtually ever. So that you don't see that there. And you may get a little bit of dyskeratosis like up here, acantholytic dyskeratosis, but this is far more diffuse acantholysis than you would ever expect to see in Derriér's disease. So the point is, you can see some of the changes of these other diseases in Hailey-Hailey like this, for example, but that wouldn't be the best answer. So it wouldn't be the correct answer if you chose one of those. The best answer would be Hailey-Hailey, and they'd be testing, does the examinee understand that you can sometimes see features that can simulate pemphigus vulgaris and sometimes simulate Derriér's disease, sometimes even simulate superficial pemphigus, possibly. So you don't want to go down that rabbit hole focusing on just one thing. Look at everything in context. Look at it as a sort of a constellation of all of the findings, and putting everything together. When you get this much acantholysis diffusely throughout the epidermis, far more likely to be Hailey-Hailey itself. If you see the Hailey-Hailey form of Grover's disease, it's a very small focus of full thickness acantholysis. It's not this large plaque-like lesion that you would see here. And you can imagine this patient's going to have this macerated, weeping, wet tissue paper-like morphology to their skin in the area that's involved. One final, so they might ask you something about the pathophysiologic mechanism of this too. I think they know now what sort of causes this. It's sort of similar to Derriér's, I believe. What's one other thing that you would maybe want to do here to make sure that you're not that can help to improve the therapy of Hailey-Hailey disease? What's one of the secondary problems that develops in patients with Hailey-Hailey?
I'm not sure.
They can get secondary infection.
Okay.
So they can get Candida, they can get staph. So you want to, usually we'll often do like a special stain. I don't really see any changes of that here, but sometimes we'll do a PAS stain to make sure they don't have secondary candidiasis or a fungal infection. You can treat those and it gets better. Obviously, that's not going to get rid of the entire process. I think they've tried JAK inhibitors with this lately, as I recall. So, JAK inhibitors are the new panacea for every disease, but it may have some benefit in this condition. So I would recommend knowing a little bit about potential therapy that might work. Okay, so we've got this in to see which is.
I can take this one.
Okay, good.
All right, so here we have a shave, likely on an acral surface because of the stratum lucidum.
Good.
And then initially what I see is probably a little bit of acanthosis. I see some vessels right underneath the epidermis. And then the thing that kind of strikes me on both this cut and the next cut is you've got this material kind of underneath this keratin kind of plug. So initially my brain went to some form of perforating disease.
Good, excellent, very, very good. So what happens in the so-called perforating diseases? What's the general theory of what's happening there?
So the general theory would be some form of like transepidermal elimination of elastic fibers, collagen, some form of foreign material, something that's creating a channel through the epidermis.
Good, excellent. And in some diseases like the perforating folliculitides and things like that, it's probably largely related to trauma, and then it kind of causes damage, and then the collagen gets damaged, or maybe the elastic fibers, and then it sort of gets sort of transepidermally eliminated. But I think it is a mechanism of the host to take foreign things and try to get rid of them. And when you scratch your skin, if you have renal disease or whatever, and your collagen is altered because of uremic circulating, toxins or whatever, it becomes almost like a foreign body. And then these channels form and they get transepidermally eliminated. So yeah, that's exactly right. So what's getting transepidermally eliminated here?
Initially I was thinking it's a little purple in the center, so maybe some component of calcium. maybe some collagen.
Okay. Anything else?
You could think of elastic fibers, or maybe just foreign material, maybe bone. Oh, okay. It kind of looks a little bit like bone.
Yeah. This is bone. There is bone
So
here.
yeah.
Look carefully. These are probably little residual cartilage here. These are chondrocytes that are undergoing ossification, and there is a little bit of collagen at the periphery, and then you got some inflammation up here. Okay. So how do you put this together? What's going on here?
So some form of old collagen that's now calcified is being perforated. As far as differential,
What do we call this when it's bone in the skin?
oh, like calcinosis cutis?
Well, that's if there's calcium in the skin, but what do we call it?
Osteoma
Osteoma.
cutis.
Osteoma cutis. Good. So that's basically what this is. It's ossification, bone in the skin. What is this material here? What are some of these little cells here? Most likely, kind of in the center of this little bony spicule. Some of these are osteoblasts here and osteoclasts. There might even be some bone marrow. And there actually is, when you get these little osteoma cutis lesions, they actually sometimes will actually develop bone marrow in them. They're bone, so they can get bone marrow, interestingly enough. And there are examples in the literature of diagnoses of leukemia made on the bone marrow of osteoma cutis. There's not a lot of bone marrow in this little osteoma cutis lesion here. Now, given the location where we are, you've got bone, and we've got a shaved biopsy of bone. Let's just say the diagnosis here is osteoma cutis. That's being transepidermally eliminated. What's another way that you can get a biopsy that samples some bone in an acral location?
I mean, could you have like a fracture? I'm not sure.
Fracture. An osteochondroma, or a little bone, little benign neoplasm of cartilage and bone. Basically, they often occur in people that have osteoarthritis, distal digits, and they're often associated with digital mucus cysts. Truly aren't cysts, they're little focal cutaneous mucinosis from the fibroblasts that sort of get irritated, if you will, by those bony spicules that form there. So we often see osteochondroma that gets shaved, and clinicians think there may be warts or something like that, or maybe even squamous cell. They shave biopsy, and they actually get into the bone when they take their shaves. We see that on occasion also. That's possible what this is here, that this might be the surface of an osteochondroma that was traumatized, and then it become, the body recognizes as foreign body and starts trying to transepidermally eliminate it here. It's a beautiful example of that transepidermal channel that you pointed out. Absolutely. Now, what's one thing that you should pretty much always do before you take a biopsy of the nail unit or often the distal digital area of the body? What's something that would be a good thing to do clinically before you plunge in with a scalpel and start shaving, with wild abandon? We don't generally tend to think of it in dermatology. That's why I'm asking it as a question.
Probably an X-ray.
Good, excellent. Yeah, always think about doing an X-ray before you biopsy the nail unit or biopsy the distal part of the finger or something like that, because there might be an underlying bony tumor that you can pick up with an X-ray. Occasionally, it might even be a malignancy or something. But it's, generally before you kind of slash into the joint space, you might want to just make sure that you're not going to do that. It's helpful. Dick Scher, he used to teach us nail dermatology years ago. He would always harp on that. He said, always do an X-ray before you biopsy. And there's a lot, we don't tend to think of imaging studies in dermatology. Our number one technique that we use is a skin biopsy. So think in terms of doing occasionally like imaging study of the head and neck area. x-rays of the digits, things like that in certain settings before you just do a biopsy sometimes. Okay, very good. One
Dr.
final.
Cockerell, I have a question. Is that okay?
Sure.
Is this biopsy cytosis and you didn't necessarily do the x-ray before?
I'm sorry, I didn't, you kind of cut out for a second.
Sure. If the practitioner didn't get an x-ray before and did shave like a bony prominence on the digit, would this be what a subungual osteosis would look like?
Yes, basically that's kind of similar to osteochondroma. Yeah, it would look very, very much like this. Exactly.
Thank you.
Okay, let's look at the very last one. It's a very small biopsy, but I think it shows the features.
Okay, I can take this one. So I think the top slice was a shave and this is a punch. And what sticks out to me is the subepidermal split or blister. And underneath it, this like baby pink kind of sclerosis. So I think for this one, you could go down either the sclerosing dermatitis pathway or the subepidermal vesicular.
Is it possible that they're related?
Yeah, I think yeah, I think you could reach the same diagnosis. So with the
Is actually a subepidermal blister when you look at it?
I thought so. But I guess, are you saying like a blister or a vesicle?
I agree with you. It is a blister. I totally agree with you. I think it is. But there's actually, we always think of blisters as being intraepidermal and subepidermal, but there's a third category.
Like subcorneal?
Okay, maybe there's a fourth category. Okay, I was thinking that's more intraepidermal. But yeah, actually intradermal blister. So in other words, the blister actually occurs in the dermis that's altered. Okay. So you've noticed quite correctly that there's sclerotic, I like your term, baby pink color to this collagen here, which is sclerotic. And which part of the dermis is sclerotic here?
The papillary dermis.
Okay. And sometimes when the papillary dermis becomes sclerotic and edematous like this, filled with liquid, it actually can split in that area. So it's an intradermal blister. So if you see here, there's actually a little bit of residual sclerotic collagen here. And then here's where the blister is. So it's actually not truly subepidermal. It's actually, I mean, it is subepidermal, but it's not occurring at the split just beneath the epidermis here, interestingly enough. So this blister is actually occurring because this papillary dermis is altered. It's edematous, and then it just basically forms a blister. And we see this in this disease very frequently. A lot of times it's got a lot of red cells in here. It's a hemorrhagic blister. So what's the diagnosis?
I was thinking lichen sclerosus at atrophicus.
Yeah, that's exactly what it is. And it's got this, it does have a blister. So that's good that you recognize that, but realize that you can get bullous LSNA. And it's not bullous because it's a subepidermal blister like bullous pemphigoid or pemphigus, an intraepidermal acantholytic process. It's basically because of this edema of this sclerotic collagen, and the collagen is so altered, it basically doesn't stick to itself anymore and ends up forming a blister. And you'll see this very not uncommonly. Here's another biopsy taken from another area that doesn't have a blister yet. It just shows a nice sclerotic papillodermal collagen. This person is probably, do you think this person was young or old here?
You typically see it in older females.
Yeah, and notice the reticular dermis here is also very abnormal. I mean, this is very atrophic as well. You can imagine what this skin looked like. It probably was very, very atrophic and wrinkled. And notice it's also got a thick cornified layer. That's because it's poritic. And these patients often, rub these lesions too, and that sort of makes these blisters develop even more frequently. So, and these can be erosive. Be really obviously a pretty bad disease. So this is a beautiful example of lichen sclerosus. what's the one item in the last minute that you sort of have to at least put in the differential diagnosis of sclerosis of the papillary dermis like this, that's not lichen sclerosus?
Like morphia?
Usually morphia won't involve the papillary dermis to this degree, and it's more of reticular dermis involvement. But radiation therapy, chronic radiation dermatitis will also give you sclerosis of the papillary dermis, often can changes in the reticular, but you get a lot of sclerosis that can simulate LSNA. So good. All right. Well, thank you guys for the session this morning. Good job. And we will give you another set of unknowns for next month.
Thank you.
Welcome.